So thank you very much. I already got the first question that I knew I was going to get, which is, so you're a middle-aged man, and what qualifies you to talk about menopause? Well, I started studying women's health in about 1999 when I graduated from medical school. Went to residency at Mayo Clinic and had 4 wonderful years there, learning all about women's health and how to care for women. And I also have a wife of almost 23 years who is starting to experience some of these things, and a mother-in-law who have both gone through it. So first and second-hand experience. I have had a hot flash, believe it or not. Any man who would like to experience one, there is a drug called niacin, and if you take enough of it, it'll lower your cholesterol, and it'll also give you hot flashes. So I have had a hot flash before. So we're going to talk a little bit about menopause today. So objectives today, we'd like to give you a basic understanding of what menopause is, discuss the common symptoms and how to treat them, review what's new out there in the literature, what you might see on TV for ads for new drugs, and talk about those a little bit, and hopefully entertain you a little bit and inform you at the end of the day. So that's the goal. Why do we care about menopause? Well, being an OBGYN, by the year 2020, we found out there's going to be about 50 million women that will be of menopausal age. So it's a good thing for me to know a little something about, seeing as that's the demographic that I treat. The typical symptoms of menopause and perimenopause really are that you get vasomotor symptoms. Vasomotor means basically that your brain signals to your blood vessels start to go a little bit haywire, and for whatever reason the hypothalamus, which is a part of the brain, starts to signal your body that you need to be warm now, and all of a sudden your vessels dilate, your face and your chest turn red, you sweat like crazy for about a minute, and then it stops. And then you're wet and cold. So that's what a hot flush really is. And it's something to do with how the brain responds to estrogen and how much estrogen is around. It also goes along with the chills, like we talked about, with some anxiety. Anxiety can cause it. It can cause anxiety with regards to hot flashes. You can imagine waking up wet and cold can cause sleep disturbances. People can experience palpitations or their heart beating fast. After menopause or around the time of menopause, bone loss accelerates, meaning that your bones get thinner. And the biggest loss in bone density occurs in about the first year to year and a half that menopause happens. So we have to be cognizant of that and start talking about watching bone density around then and treating it if the bones appear to be too thin. Really trying to prevent hip fractures and lower back issues. How long does menopause or perimenopause last? There's actually a really good recent study at the University of Pennsylvania called the Penn Ovarian Aging Study. They followed a large group of women from age 42 to 50 and found out that the median duration, or the middle, almost the average, of experiencing moderate to severe hot flashes can last around 10 years. So it's not a sprint, it's a little bit of a marathon. It can be more significant for women of color and for women that are obese. So it can last longer. How did we get here? So when I was in residency in 1999, one of my professors I remember really well, we were talking to a woman who was about 52 and just had gone through menopause. And his treatment plan was to put her on estrogen, and the reason being that, well, if your thyroid quits working, we give you thyroid medicine, and stands to reason if your ovaries quit working, why wouldn't we give you estrogen back? And you feel better on it. It does treat the hot flashes, and so the vast majority of doctors in that time frame were putting most all of women on estrogen right around menopause. And it was effective treatment for those symptoms. There were some studies that suggested maybe it actually decreases your chances for stroke, heart attack, maybe dementia, and osteoporosis. Through the late 90s, it was common practice until 2002. And then the Women's Health Initiative study came out. I don't know if any of you have heard of that or read it, but that was kind of the apocalypse for hormone replacement therapy as we know it. So what happened then? Women's Health Initiative was a very large study called a prospective study, meaning they took a large group of women, gave placebo or sugar pills to half, and gave hormones to the other half, and then measured a bunch of things to see what would happen. And tried to determine, is this a good medicine to have everybody on? Is it reducing your risks? Is it treating what we think we're treating? And turns out that as a primary preventative medication, it is probably not a good thing to have everybody on, because the risks that it puts a woman into, such as stroke or heart attack, actually do go up compared to women that were on just sugar pills. And I'll go into more detail about which medicines and what those risks are. So overall, as a preventative medicine, we've determined that probably not a good thing to be on long-term into your 60s, beyond your 60s in particular. The big criticism of this study is we think they studied the wrong group. The women that really need the hormones are women that are going through perimenopause, starting in the mid-40s, going through probably the late 50s. And the minority of women in this study were actually that age. So really this is a study telling us older women probably shouldn't start estrogen if they haven't already been on it for preventative care. Again, I'll go into more detail about what that means. So since we've basically taken the majority of women off of estrogen, because we know, okay, it's not a great medicine to be on long-term for prevention, the younger women may actually be doing not quite as well, and this is an unintentional side effect of that study, in my opinion. Since 2002, when that study came out, only about a third of women in the right age group are actually probably on hormones where they could benefit from them. Some statistical modeling has suggested that maybe that group of women is dying younger than they should be because we're avoiding estrogen in all these women now. This is not a prospective study like Women's Health Initiative was, so you have to take that study with a little caution. But those follow-up studies are being done. So how do we treat hot flashes? Again, now we're not talking about primary prevention for stroke, heart attack, bone density. We're talking about treating these miserable hot flush symptoms. Behavioral treatments. You saw me turning down the temperature in here. I know my audience. Fanning, dropping the thermostat, dressing in layers so you can peel off a layer if you feel like you're getting too hot or having a hot flash. Avoiding things that irritate or are more likely to cause hot flashes, in particular tobacco, alcohol, all the good stuff, spicy food, caffeine, and then drinking more cold beverages to try and treat the hot flashes. Hypnosis has actually been studied. So there was a good RCT, means randomized controlled trial of 187 women where they took half of them and used a specific hypnosis versus another group where they just said, okay, when you get a hot flash, we're going to have you stare at the wall at a specific spot and wait it out. And women that went through the hypnosis arm actually had a 3/4 or a 74% reduction in the number of severe hot flashes that they had versus about 20%. The problem is, do we have enough people that do hypnosis that can actually treat women? So remains to be seen. I bet you'll see that pop up here and there though, and it can be effective. I get a lot of questions in the office about black cohosh, herbs, soy products. They have studied this, published in 2006 in the Annals of Internal Medicine. They looked at actually the majority of these things versus placebo, and then also hormone therapy versus placebo, or placebo means the sugar pill. And hormone therapy works, the other things really don't show an improvement, so if you want to do black cohosh, fine. It's not really helping you more than a Tic Tac would, so just so you know that. All right, so other non-hormonal medical treatments for hot flashes, so I'll translate the medical jargon up there. Basically, SSRIs and SNRIs are versions of an antidepressant, but they actually do show clinically, when compared with placebo, that it will reduce hot flashes in at least 30 or 40% of women, depending on the studies that you look. Some of them are now being marketed also as treatment. Paxil, for instance, is one that they're looking at. Effexor and Wellbutrin have also been looked at as treatments for hot flashes, and they are effective. My experience, not quite as effective as estrogen, but they do work. Gabapentin and pregabalin are cousins of each other. Neurontin is the trade name for gabapentin, and those also have been shown to be effective against the sugar pill. Paxil and Prozac. You have to be a little bit careful as a provider when you prescribe these medicines to women who have had breast cancer and are taking tamoxifen, because it may actually inhibit the active form of tamoxifen or the creation of the active form. And we don't want to inadvertently, trying to treat hot flashes, have a result of increasing the likelihood of recurrence of a breast cancer. And then something called a stellate ganglion block. This is something that's a little bit out there. They're actually putting a needle into the brain near the hypothalamus where the problem is starting, and injecting a medicine to block that. I don't know that I would be the one to sign up to have it tested on me, but it has been shown to be effective in a few studies. I would wait until you see a little more research on that one before I'd sign up for that one. I get a lot of questions on bioidentical hormones. What is a bioidentical hormone? Broad definition, basically it's a medication that is identical to what your body would have already made. If you look at two of the medications we prescribe that are actually regulated by the FDA, they are in fact bioidentical hormones. Estradiol is in fact bioidentical, and then one of the versions of the progesterone that we give through a pill is also bioidentical. The problem with bioidentical hormones today is that some of the people that are prescribing them are actually probably getting some monetary influence from the company that compounds the ones that are not FDA regulated. They're advocating salivary hormone testing, so from your saliva to see what your levels are, and there really isn't good data to say that actually mimics the levels that you would get if you tested it in your blood. Some of the compounded medications that they've tested have either a lot more or a lot less estrogen than what they think is in there when it's been studied. So for my money and for my risk profile, I would preferably have you on a medication that we know what it does, we know how much is in it, and it's regulated by a government agency that we can at least ostensibly trust. So that's my 2 cents on bioidentical hormones. And yes, Chrissy from, what is her name, from the TV show back in the 70s is beautiful and promotes it everywhere. From Three's Company, yeah, Suzanne Summers. But I'm pretty sure she's getting monetary influence there as well. And also remember, from your own hormones, I mean, just being a woman, you have a 1 in 8 chance lifetime risk of getting breast cancer. So your bioidentical hormones put you at risk for that. So for them to claim that there is no risk proven from bioidentical hormones is just not true. And 1 in 2 women get heart disease. So just to keep it in scope. So new medications. There's one that you may or may not see on television or may have seen in the last couple of years that came out called Duvet. It's got a selective estrogen receptor modulator. It's in the same family as tamoxifen. So basically what that means is it works on some of the estrogen receptors on some of the tissues in the body, but not all of them. And so they've looked at this class of drugs as being a potential solution for particularly people that have an increased risk for cancer, to stimulate the right receptors and not the wrong ones. Makes good sense. This particular one, they've combined with estrogen, and it has been shown to decrease hot flashes. It improves bone density like estrogen would by itself. Does not increase the risk of thickening of the inside part of the uterus, which is one of the risks of estrogen. We know women on unopposed estrogen have a higher chance of getting precancerous or cancerous changes within the uterus. So it is indicated also for treatment of hot flashes and thin bones. It costs about $165 a month. It's a little bit more than what estrogen would typically cost. So I haven't prescribed a lot of it. They have not conclusively studied it and what its association is on people with an increased risk for breast cancer. So you have to be a little bit careful until we have a little bit more literature on this drug. So treatment, most effective treatment for hot flashes we know is systemic estrogen, or basically estrogen by pill, patch, or cream. It can increase the risk of thickening of the uterus like we talked about. We know from that Women's Health Initiative study in 2002 that if you add back a progesterone to the estrogen in a woman who has a uterus, it will reduce those risks back to baseline. So basically you're covering up the risk that estrogen introduces. Sequential versus continuous treatment means basically continuous treatment is you take both hormones all the time. Sequential means you take active hormones for 3 weeks and then you get a week holiday. If you use continuous treatment, it actually decreases the risk to a better level than sequential treatments. We'd rather have you taking the pills all the time to appropriately reduce that risk if we're going to do it. So what's a girl to do? There is some good literature on the web, actually, and one of the organizations that has a lot of patient-friendly materials and also doctor-friendly materials is www.menopause.org, and it's put on by the U.S. Menopause Society, I believe is what it's called. And then there's an app that goes along with it that you can download onto your smartphone and do a little of your own research if you want. And actually, I have used this app, and it is pretty helpful. It can help you individualize treatment based on what your individual risk factors are for different cancers, stroke, heart attack, high blood pressure, and the like. So the other topic that kind of goes along with the menopause is something we now call genitourinary syndrome of menopause. When I was in training, it was called vulvovaginal atrophy. Apparently, the college, we now call it the college, the American College of OBGYNs, has decided that the words vulva and vagina are too embarrassing to say in front of patients, so we're not allowed to use that terminology anymore. I've been doing it for the last 17 years, and it hasn't bothered any of my patients, but as far as I'm aware anyway. So what happens after menopause, specifically to the genitals? The vagina tends to shorten and narrow. It can make sex quite uncomfortable. The lining of the vagina itself actually thins out. There can be a reduction in secretions of the glands that are in the vagina, and in effect having less lubrication. A lot of women describe just a sensation of being aware of their vagina that they weren't in the past. Sex becomes painful. Sometimes you can get a chronic kind of watery discharge as a result from those cells not maturing like they're supposed to. So that's what that means. There are non-hormonal treatments for this. If you walk through Walmart or Target and look in the pharmacy, there are long-acting lubricants like KY gel beads that you can put them in vaginally, and they slowly dissolve and provide lubrication longer term. Medicines like Replens are meant for that as well. Those that are struggling with intercourse, that are still having intercourse when they're into the menopause, and those types of symptoms can actually use dilators to help the vagina, again, accommodate for intercourse. And then again, regular intercourse, believe it or not, if you don't use it, you may lose it. So if you have regular sex, it's probably going to go better than if you just stop. There is a new treatment that I actually just heard about in the last month that we're looking into, that is use of a laser vaginally that actually causes a little bit of tissue disruption locally to the vagina and can help that tissue remodel without using estrogen. It's still fairly new, so I'm waiting for a little bit more literature to come out on it, but we may end up trying to pursue that locally for those that can't or don't want to use estrogen. So hormones for this also are very effective. Topical estrogens such as estrase or Premarin, estrase being estradiol, which is a bioidentical hormone. Used at that dosage, which I don't expect you to remember or know, but if you come and see one of us in the clinic, we can certainly talk about getting you started if you want to try topical estrogen for that treatment of those symptoms. The nice thing about use of topical estrogens is it really doesn't bump up the serum levels of estrogen in your body, so you really shouldn't have the increased risks for things like stroke, heart attack, blood clots that you would get if you were taking oral estrogen. And then for hot flashes, we didn't really cover this earlier, but you can use estrogen via a patch, which lowers the risk of some of the side effects like DVT and strokes that are associated with the deep vein blood clots. That oral estrogen definitely increases the risk for. Androgens. Androgens are male-type hormones like testosterone. Those have been studied for women that have libido issues after menopause. Really not so much for women that are premenopausal. The doses that we would have to give to have an effect are what we call supraphysiologic, or higher than what your adrenal glands would make in your body before menopause anyway. And they do have some side effects. Your voice may deepen. You may get hair growing where you don't normally get hair growing, like your chin, your chest. You may get enlargement of the clitoris and swelling of the labia. So most people rather would not incur those side effects and choose not to be on the testosterone. Some things people don't know about testosterone: if a woman does take it, your body naturally converts it to estrogen, so it may have some of the same risks as estrogen, such as increased risk of stroke, heart attack. And obviously we don't want to do that for the sake of libido if it's not that big of an issue. A newer med, Athene or ospemifene, it's another one of those selective estrogen receptor modulators, so it works on some of the hormone receptors, but not all of them. It's been put out there, indicated to reduce those atrophic changes vaginally. Unfortunately, one of the side effects is it can cause hot flashes, so it's kind of pick your poison on that drug, I think. I have not had that one as being real popular for being prescribed in my office because of that. It has not been studied in the arena of breast cancer risk or DVT risk, so more to come on that drug. There may be some potential for it. Special populations, so early menopause, early ovarian failure, or surgical menopause. Actually, the Mayo Clinic did a study on a fairly good-sized population of women in Olmsted County right here in Minnesota, and looked at women that had gone through early menopause, and without adding hormones back, we definitely know it does increase their chances for osteoporosis, heart disease, including dementia, macular degeneration, which is a change in the eyes that costs people their vision. Glaucoma is more common, stroke, and then also possibly overall mortality for women that have early menopause, whether it be due to surgery, to chemotherapy, or their ovaries just stop working naturally early. For those women in particular, it needs more study, but the common thought thread is that you'd have had normal estrogen production from your ovaries probably into your early 50s. So some sort of estrogen replacement up until then is probably a good idea until we have a little bit more knowledge from the literature, and probably reduces the risk of the majority, if not all of those things. Those who have had personal history of breast cancer, fairly clear in the literature that we probably don't want to have you taking oral estrogen. It probably increases your risk for recurrence of breast cancer. One interesting sidebar, the Women's Health Initiative, the type of estrogen they used in that study were conjugated equine estrogens, or Premarin. Some of those estrogens may actually have a little bit of an anti-estrogenic effect on the breast. And we did see, I believe it was in all phases of the study based on age, a reduced risk for breast cancer in women that were on estrogen only, and it would have been that type of estrogen. So they think that might be why. If it was estradiol instead, it might have not shown a difference. We don't know that for a fact. They may be looking into that a little bit more. We mentioned earlier low-dose vaginal estrogen does not increase blood levels of estrogen, and probably is okay to use. You would definitely want to consult with your oncologist, though, before starting an estrogen after having had a breast cancer, even if it's just a vaginal cream. Observational studies, again, you have to be a little bit careful with observational, where you're taking a case control group, so you have women that have had breast cancer and then women that haven't, and looking back into the past at who was on estrogen, who wasn't, and trying to make an association, versus prospective studies where we take a group of women, divide them in half, placebo to half and drug to half, and see what happens going into the future. Those are typically better studies, give us better information. So I don't typically make recommendations just based on observational studies. So we still want to look at estrogen use in women with history of breast cancer. And then kind of the last special group, those that have the genetic tendency to get a breast, ovarian, uterine, sometimes colon cancer. It's called BRCA or BRCA, and there's two versions of that, 1 and 2. We do know that those women who have not had a breast cancer yet with that particular gene, they do benefit from mastectomy. They're less likely to get a breast cancer if they're carrying those genetics, and they do benefit from having their ovaries removed, particularly before menopause. And it can reduce their risk for getting a breast cancer by up to 60% over those who leave their ovaries intact until menopause. And then they have looked at that particular group of women and then used estrogen for hot flashes, or CEE, which is the Premarin. And it does not appear to forfeit the risk reduction from removing the breasts or removing the ovaries before a cancer develops. So take-home message, that app is nice if you have personal individualized risks. You can plug in your age, some various questions it leads you through, and it'll tell you, okay, maybe you want to try this medicine for these symptoms, and this is the dose. Helpful to go through it with your doc. If you have a uterus and are using medication for hot flashes, you should also be on a progesterone if estrogen is the medicine. We talked about the patch being a little bit preferable to the pill for decreased risk in blood clots in the legs. And the new meds, I'm still waiting on a little bit more literature to see if those are beneficial compared to estrogen. If all of this is going over your head and you need me to explain it in person, we do have openings, and you do not need a referral. Several people have asked that. You certainly may get a referral from your primary doc if they can't answer those questions, but you can just make an appointment and come and see Dr. Gildner or myself. We do have a new doctor starting in September. If you're a little put off by the fact that the only gynecologists in town are men, there is a female that's going to join us in the fall. Katie Johnson is her name, and I'm sure she's going to be a big hit. So I think that's it. Thanks for coming, everybody.
Thank you.